It's 2 in the morning. You walk into a dimly lit hospital room and find your patient trembling. Sweat is soaking through their hospital gown, and when you ask a simple question, they just stare back at you in total confusion. You have about 30 seconds to figure out the ending to this story. Is this the beginning of severe sepsis, a sudden stroke, or a dangerous side effect of the insulin they received hours ago? I'm Brooke Wallace, a 20-year ICU nurse and clinical instructor. My mission is to help you take textbook pharmacy and apply it to the real breathing patient right in front of you. To sharpen your clinical judgment for the floor and the NCLEX, hit subscribe and visit the SuperNurse platform for our full range of bedside resources. Navigating these high-stakes moments requires a reliable understanding of how medication timing directly triggers the physical reactions you see at the bedside. Let's look back at the start of the shift. For a new nurse, a complex diabetic medication record can feel like a minefield of hidden traps, especially when multiple types of insulin are involved. This chart shows the behavior of rapid and short-acting insulins like Lispro, Aspart, and Regular. These are your sprinters. They reach their maximum strength, their peak, in a narrow window of 1 to 4 hours. Then there's intermediate NPH insulin. It's physically cloudy in the vial, and its peak is much wider and delayed, exerting its strongest effect anywhere from 4 to 12 hours after you give it. Finally, we have long-acting insulins like Glargine and Detamir. These provide a steady baseline coverage for 24 hours because they have a flat release profile that lacks a peak entirely. To limit the number of needle sticks, you'll often mix these in one syringe. The bedside rule is clear before cloudy. You draw up the clear, regular insulin first to ensure you don't contaminate the fast-acting vial with the cloudy, delayed action proteins found in NPH. But the core logic of insulin management is simple. You must match the medication's peak action time directly to the delivery of the patient's meal. Failing to align that biochemical peak with caloric intake sets a trap. If the insulin is working at its strongest while the stomach is empty, the patient's blood sugar will plummet. Back in that room at 2 a.m., the mystery is solved. The patient's evening dose of NPH insulin has just hit its peak while they were fast asleep. Because the brain doesn't store its own energy, it relies on a constant supply of glucose from the blood. When that NPH peak forces too much sugar into the body's cells, the brain begins to starve. In a panic, the body triggers an adrenergic response, dumping adrenaline into the system to force the liver to release any stored sugar. That intense adrenaline dump is exactly what physically causes the shaking, the tachycardia, and the profuse sweating you're witnessing at the bedside. Even when a patient is combative and the room feels chaotic, a clinician must suppress the instinct to react blindly. You cannot treat a patient for hypoglycemia based on a hunch. The non-negotiable rule is that you must always check a blood sugar level before administering any treatment. Taking 10 seconds to verify objective data ensures you are treating the actual problem rather than compounding a medical error. You check the finger stick and the glucometer confirms the crisis, 42 milligrams per deciliter. Because this patient is lethargic and confused, their gag reflex is compromised. Forcing them to swallow apple juice now creates a high risk of aspiration. You'd be trading a blood sugar crisis for a respiratory one. Instead, you go directly into the vein. You push a life-saving bolus of D50, sending concentrated fuel straight into the bloodstream to the starving brain. As the glucose levels rise, the symptoms subside. The tremors stop, the sweating cools, and the patient begins to respond to your voice as their central nervous system recovers. By replacing the initial uncertainty with a methodical clinical assessment, you've maintained control of the situation and kept the patient safe. This confidence is earned through the combination of pharmacological knowledge, physiological assessment, and the discipline to verify data before you act. To wrap up, always memorize your insulin peaks so you can anticipate when a crash is likely to happen. Look for the physical signs of an adrenaline dump, the sweat, and the tremors. Above all, verify the blood sugar first and let the patient's level of consciousness determine if you use oral carbs or an IV rescue. Thanks for watching. Let me know in the comments which bedside scenario we should decode next.